Hello, this is my week 6 evaluation on substance abuse and how it relates to opioid abuse. Um, our first bullet point talks about assessment findings, both physical and psychosocial, that may indicate substance abuse. Um, First off, the mechanism of action of opioids. Our book describes morphine uh, in its description and states that it occupies the mu and the kappa receptor sites in our brains and our dorsal horns of our spinal cords, and that alters the release of afferent neurotransmitters. Um, that means that the dominant effect alters the perception and emotional response to pain, producing an analgesic effect and or a euphoric effect. This mimics our body's natural actions of endogenous endorphins. Um, Really, what that's saying is that and most opioids uh, present a CNS depressant reaction. So most people who are abusing or using these opioids are going to have some sort of respiratory depression, some sort of causative sedation, maybe dizziness, anxiety, feelings of floating or disorientation, even hallucinations and or seizures at high doses. Um, some of the physical uh, superficial effects you may see: inflamed nasal mucosa due to routes of ingestion, perforated nasal septums, bruises, lacerations, scratches, needle marks, skin abscesses, cellulitis, even jaundice. Um, Opioids seem to have an effect on the sphincter of Oddi, which causes a bowel obstruction, therefore causing a lot of jaundice in certain individuals. Um, our second point talks about the behaviors that patients may demonstrate when they are abusing these medications. Um, what I found was a description of opioid intoxication. This intoxication level includes conscious sedation. They may be drowsy, slurred speech, even nodding, almost nodding off into an intermittent sleep, um, memory impairments, euphoric moods, pupillary constriction, things of that nature. Other indications could be withdrawal indications. These are listed into 4 grades, grade 1 being the lowest and grade 4 being the highest. Um, Grade 1 includes lacrimation and or rhinorrhea, diaphoresis, yawning, restlessness, and insomnia. Uh, Grade 2 includes dilated pupils, piloerection, muscle twitching, myalgia, arthralgia, and abdominal pain. Level 3 would include tachycardia, hypertension, tachypnea, fever, anorexia, nausea, and extreme restlessness. And the highest of these is grade 4, exhibits diarrhea and or vomiting, dehydration, hyperglycemia, hypotension, and could even be found in like a curled up fetal position as well. Um, those were all withdrawal symptoms there. Um, the practices that I found that would assist healthcare providers in interventions in the management of patients who do abuse these opioids. Um, a lot of things discuss screenings and assessments and referrals, um, making sure that we're screening these patients and doing proper assessments um, to find um, any type of mental or physical abnormalities that may need to immediate intervention and ways that these drugs are interacting with their bodies both physically and mentally. Other things were having mental health consultations and psychiatrists provided for patients to be able to use. Um, it's crucial for their sustaining recovery and stable functioning as patients who do abuse these drugs. Another thing that these psychiatrists offer are further assessments, diagnosis tools, um, medication regimens, and also rapid responses to crisis as they may happen. Um, the biggest thing about having on-site psychiatrists as opposed to having the patient have to find one is the fact that it's more convenient. They don't have to separate from one clinic to another. They don't want to be labeled as mentally ill and have to go tell their story to multitudes of other people when they can just do it in kind of one area. Um, Another part of that is this psychoeducational classes that they offer um, patients and abusers who are able to um, discuss their disorders and the medications they take and the effects and signs and symptoms on how they can be aware that if they are having issues that they can come seek medical attention. Um, this also creates a positive environment and lets things be out in the open for them to talk about. Our last point discussed is how we've had any possible patients that we've dealt with substance abuse and any dilemmas that we've encountered. Um, I do have and deal with a lot of outpatients that come in. They, I do have a lot that take, a lot of chronic pain medication, um, morphine, hydrocodone, hydromorphone, um, lots of opioid, chronic pain management. But generally, I'm pretty genuine with them. Ask them open-ended questions. I let them tell me, what they're going to tell me. A lot of times they tell you a lot more than you really ask. Um, so a lot of times they're able to get these things off their chest that they may not be able to tell anybody else. Sometimes this opens their eyes up to maybe they do have a problem. Sometimes it doesn't. Biggest thing is just making sure that it's judgment-free and that they're able to feel comfortable and able to tell you these things. That way, if they are having an issue, you can certainly help them. A lot of times they're just not sure what to do with their pain. They've been in chronic pain for so long. They're not sure of other alternative therapies. These are things that we could teach them. Um, the biggest thing in my area is that if we do get anybody that's post-procedure that is in a lot of pain, we may offer small doses of morphine or dilaudid on rare occasions. But generally, if we have any patients who are adamant about any type of pain medicine and obviously not exhibiting signs of pain with, without guarding, grimacing, higher blood pressure, heart rate, the typical symptoms that you would find with somebody who's in acute chronic pain. Um, we will definitely refer them to pain management clinics across the street from where we work so that they can get the treatment that they need. Um, it's a very interesting topic, and hope I can learn more about it to be able to help more patients as I see them on a daily basis.